Why don't you go ahead and get us started, Chris?
All right, sounds good. Hey, everyone. Thank you for joining. My name is Chris Contra. I'm the Executive Director of COVID Survivors for Change. We are a nationwide community where we support survivors, we remember those who have died, and we advocate for stronger pandemic policies. And we do that by offering trauma-informed resources. For example, we have COVID Connections, which is our free weekly support group led by mental health professionals that has provided more than 4,500 hours of free support since 2020. And we take action to bring about legislative and cultural change. Most recently, we've been fighting to raise awareness about the more than 300,000 children who have lost a parent or a caregiver to COVID. Last year, we fought with other groups in California to make sure that $115 million was advocated to in the budget for baby bonds, which are publicly funded savings accounts that can be used when a child turns 18 for college or starting a business or purchasing a home. And that's a policy that we fought in California for children who lost parents or caregivers. And last month we were able to introduce a scholarships bill in New York, and then next month we're expecting that baby bonds bill in New York as well. So trying to do more to raise awareness and push for support in New York and other states like Italy did last year in California. I'm going to hit the record button, and we'll post the recording afterwards. All right. Andrew, it's saying I need permission from you to record. So maybe you want to do the recording. And just so you know, closed captions are available. And if you would like to use that, you need to enable them from your toolbar. And thank you again so much for joining this COVID-19 Health and Safety Task Force webinar. We're going to be discussing the end of the public health emergency, and end is intentionally in quotations, because we know that even though the public health emergency is ending, COVID is not over. So this is a conversation with experts to talk about what's changing, what that means for you, and to help you navigate this next stage of the pandemic. We'll be discussing the history of the public health emergency, what will be changing after it ends, and how this will affect patients' access to care, including post-acute COVID-19 care. And we'll also discuss how the end of the public health emergency will impact our response to the pandemic and really public health generally. We do have a Q&A, and if you have questions, you can drop that in that Q&A function, and we'll be going through and moderating those questions throughout. And with that, I'm going to introduce our three expert panelists. First is Andrew Wylam. Andrew is a lawyer and patient advocate who currently serves as the president of Pandemic Patients, which is a 501c3 nonprofit organization that works to relieve the harm caused by COVID-19 and post-COVID conditions. As a seasoned government relations professional and public policy expert, Andrew guides the organization on its mission of providing support and services to people who've been affected by COVID. Andrew has dedicated his career to advocating on behalf of Americans living with chronic illnesses like COVID and other illnesses, and he's really passionate about elevating their experiences so that those experiences can reach policymakers all across the country. Second is Liza Fisher. Liza is a national healthcare advocate and yoga teacher who's committed to providing education around long COVID and associated conditions. After being hospitalized for months and becoming disabled by long COVID, Liza recognized the world of underacknowledged and under-researched complex chronic illnesses that are affecting millions across the country and across the world. And this led her to becoming involved in advocacy and research and in public policy. And Liza has co-authored research manuscripts. She's been a patient representative for NIH's Recovery Initiative and the University of South Carolina's COVID Patient Engagement Studio, and she has testified before Congress. She currently serves on the Long COVID Alliance's Executive Committee. And Dr. Alba Azola is our third panelist. Doctor is a rehabilitation physician helping patients restore function and movement after an injury or illness. Her expertise includes neurorehabilitation and rehabilitation for swallowing disorders. Dr. Azola currently serves as the co-director of the Johns Hopkins post-acute COVID-19 team and works at the Hopkins University School of Medicine as an assistant professor of physical medicine and rehabilitation. And with that, I'm going to turn it over to Andrew to kick us off. Thanks, Andrew.
Mentioned, I'm the president of Pandemic Patients, and we are a nonprofit patient advocacy organization for people who've been affected by COVID-19. We work to raise awareness about COVID-19 and post-COVID conditions, and we also work to ensure that people affected by COVID receive the support and services they need to live their best lives. So we're very happy to join today's webinar to provide some information to the public about the many changes to healthcare that will occur alongside the end of the public health emergency. This is an important topic for us because the end of the public health emergency will shift how we think about COVID-19, how we respond to being exposed to COVID-19, and the tools that are available to us if we experience a COVID-19 infection. So the end of the public health emergency, this is something that's coming up on May 11th, 2023. That's less than 1 month away. So this is going to change the tools we have available for prevention, diagnosis, and treatment of COVID-19. That means that vaccines, tests, and treatments might become more difficult to access. There's also changes coming up with telehealth, prescribing rules, and those will impact access to care as well. I'll talk a little bit about the Strategic National Stockpile, which will still have some supplies available to Americans while supplies last. But again, circling back to May 11th, that's the big date that we're looking at. So I want to start by how did we get here? Well, the public health emergency itself was declared by the Secretary of HHS, Alex Azar, back in 2020. And that was in response to discovering that COVID-19 was spreading around the world. And when a public health emergency is declared, there are additional flexibilities that the government has to respond to that crisis. So as it says here, when a PHE is declared, the Secretary of HHS may take such action as may be appropriate to respond to the PHE, including making grants, entering into contracts, and conducting and supporting investigations into the cause, treatment, or prevention of the disease or disorder. Additionally, when a public health emergency is declared, the Secretary can waive or modify certain Medicare, Medicaid, CHIP, HIPAA, and privacy rule requirements. They may modify the practice of telemedicine through the Ryan Haidt Online Pharmacy Consumer Protection Act. And they also may implement regulations allowing the Secretary and the DEA administrator to designate patients, location of patients, and use of controlled substances during a public health emergency declared by the Secretary. Further, it will enable the Secretary of Defense, in consultation with the Secretary, to deploy military trauma care providers during providing care at high acuity trauma centers. So there's a bunch of other provisions that also get brought in here, but these are the top of mind ones that I think people are going to see the most changing when the public health emergency ends. And so not just when the emergency was declared, but Congress took action in the years following to implement other policies that were tied to the public health emergency. So, for example, the Families First Coronavirus Response Act made it so that Medicaid had to cover testing and treatment for COVID with no cost sharing. And they also required health insurance plans to cover tests for COVID-19 without any cost sharing or utilization management. That means that pretty much everyone in America gets to go and get some at-home tests or PCR tests pretty much at no cost to them and without being subject to utilization management techniques like prior authorization. So shortly afterwards, the Coronavirus Aid, Relief, and Economic Security Act, or the CARES Act, was passed. And that made some additional policy changes, and that required coverage of COVID-19 vaccines and their administration without any cost sharing. So the reason these are important is because those policies were implemented, but they weren't going to last indefinitely. In the statute, they were tied to the end of the public health emergency. So now that we're looking at the public health emergency ending, these policies are going to be changing. So I mentioned telehealth earlier as well. With the practice of telemedicine, historically, it's been kind of restricted, particularly in Medicare. So the public health emergency made some changes that made it easier to access different healthcare services through telehealth. And so what that means is that you're not restricted in where you are or where your provider is. for accessing telehealth services, or you might not have to use a specific computer system during that telehealth visit. For example, people are able to use an iPhone or FaceTime during the public health emergency to access care from their provider, or they can access that care through just an audio call instead of having video be a component of that as well. Also, there are exemptions to state licensure requirements that have allowed telehealth to be practiced across state lines. So if your doctor is in Texas and you're in New York, the requirement that your doctor be licensed in New York to give care to you has been waived, and that will be changing. So there's a few other things on telehealth as well. One thing that is different is that health insurers have been allowed to offer telehealth as an accepted benefit, which means that it can be treated like a dental plan or a vision plan. It can be a standalone plan that isn't tied to your health insurance policy. That's something that will be changing. I haven't seen a lot of that happening during the pandemic, but I'm sure that it's out there. And for some of these changes to Medicare in particular, the updates will be happening in a staggered fashion. So some things will happen immediately when the public health emergency ends. Some flexibilities have been extended for a year or until 2024. And some changes have been made permanent. So if you were a senior, you're going to have a lot better access to telehealth generally than you did before the pandemic. But it's not like an easy across the board, everything is great now situation. There's still going to be some restrictions. So on this page, I've got an additional link for some more information where the Federation of State Medical Boards has listed out which states will still allow telemedicine across state lines. So that's a really helpful resource if you'd like to learn more about what the situation is going to be like in your state. So next, with controlled substances, during the public health emergency, patients have been able to get prescriptions for controlled substances without completing an in-person visit with the prescribing provider. And that's something that will be ending. So the Drug Enforcement Administration, they have started the rulemaking process to extend that flexibility temporarily, so that patients can still have continuity of care and coverage for controlled substances. The proposed rule closed its comment period on March 31st, so we're waiting to see really what the next step is for them, for what they'll be allowing, but I can go over some of the components of that proposed rule with you on this chart here. So really, if you're going to focus on anything here, it's in those green columns. So if you are a patient getting a prescription for a Schedule 5 to Schedule 2 controlled substance, you will need to have an in-person visit with your provider before that prescription can go through, or your provider who did an in-person visit needs to refer you to the other provider who gave you the prescription by telehealth. If you don't have that, you'll be able to get a 30-day initial prescription, but you won't be able to refill it. And if that's for a Schedule 2 or above controlled substance, you will not be able to get that prescription at all. And the reason that's important is for many long COVID patients, they are prescribed stimulants to help their symptoms of fatigue. And those stimulants are controlled substances. So if you've been getting that through a doctor and you've not completed an in-person visit, it's important that you establish that in-person care so you can continue getting that prescription. In the proposed rule, there is a 6-month grace period. So if you established care with a new provider and got prescriptions during that time, you will continue to be able to do that for 6 months after the public health emergency ends. But after that period, the in-person requirements will apply. So in the background of all of this happening, there have been, back in those statutes I mentioned earlier, they required states to provide continuous coverage for Medicaid enrollees. So that's the health program for low-income Americans. And what this meant is that states could not check their income during the public health emergency to verify their eligibility. So they had to keep them on that program for the length of a public health emergency. So originally that was supposed to end alongside the public health emergency, or within 6 or 12 months of it. But the omnibus spending bill from Congress that was passed this past December, that uncoupled these issues so that those eligibility redeterminations would begin in April of this year, and they'll be continuing for the next 12 months about. So the reason that I mention that is because the uninsured population is going to be affected maybe the most as far as anyone affected by the changes with public health emergency ending. And I'll discuss that a little more on the next slide, but I just want you to kind of keep that in the back of your mind as we go through the following slides, because as we transition here, people are going to lose their Medicaid coverage because they're no longer going to be eligible. And they will transition either onto a different source of health coverage, or they'll become uninsured. So the Medicaid program had millions of people that got those benefits during the pandemic. So there are a lot of people who are going to be going through this eligibility redetermination process for maybe the first time. So access to care. So when I talk about access to care, what I really mean is how people can afford tests, treatments, vaccines, or healthcare visits. And that's really going to dictate how we respond to the pandemic moving forward. So what I want to discuss specifically here is the vaccines. We've got the Pfizer, Moderna, and Novavax. We have tests that includes both at-home tests and PCR laboratory tests. And then it also includes treatment with Paxlovid and Legevrio. So we've seen in the past couple of months that Pfizer and Moderna have announced that the prices of their vaccines are going to go up. And when the public health emergency ends, all of these things will be transitioning to traditional health coverage. And so that means you might have a copay when you go to get a vaccine or pick up a prescription for Paxlovid, or when you go to buy at-home tests at the pharmacy. And so we kind of have to rewind in our minds a little bit to how health insurance coverage worked before the pandemic, to sort of reorient ourselves to what these changes mean for us. Because for a very long time, we had guaranteed access to these things. Those statutes that Congress passed meant we don't have to worry about paying for the at-home test. We can just go pick them up, and our insurance covers it, or we can get it through the mail, or we can just go to the Walmart corner pharmacy and get the vaccine and not have to worry about the checkout line. So when Pfizer and Moderna announced that their vaccines are going to cost more, that cost is going to be shouldered by individuals and health insurance plans. So PCR tests usually cost about $130, depending on where you get the test. If you get it in a hospital, it can often be more expensive than that. So many Americans might be faced with, I have to pay out of pocket for this now. If I get COVID, can I afford to go get tested? Or do I just want to, ignore it and not know my status and hope for the best? So for treatment, the government has been purchasing Paxlovid and Legevrio in bulk. So there were about 23.7 million courses of Paxlovid purchased by the government as of some surface research I was able to put together. And those were purchased at about $530 each. And that is a pretty good deal for the government. And now we can probably expect that the price of that in the private market is going to go up. So when someone has COVID and they get prescribed Paxlovid, they're going to go to the pharmacy and they might get a bit of sticker shock for how much their Paxlovid costs. It could cost $1,000 for a course of treatment. It could cost $2,000. It could cost more. And so that's not going to be great for health outcomes. So when a person gets exposed to COVID, they're going to have to actually decide, like, is this worth the money to treat, or do I want to take my chances? And so we view that as a pretty bad thing that we want to avoid. So that's kind of an overview of how the private market is going to work. But with Medicaid, again, that low income program, they're going to continue to offer pretty comprehensive coverage through 2024 for the enrollees that stay on Medicaid and aren't pushed off the rolls because their income changed. And Medicare, the program for older Americans, their Part B is going to be covering PCR tests, but Medicare beneficiaries won't be able to access at-home tests the same way they have been. And so that's going to make it a little harder for people to test themselves at home. And then Medicare Part D, that's the prescription drug program for Medicare. They do not cover things that are provided an emergency use authorization, which is what Paxlovid and Legembrio have. So if that doesn't change in the near future, Medicare beneficiaries might not have great access to COVID treatments and antivirals. So the big takeaway here is that the uninsured populations, they don't have private coverage. They don't have Medicare, they don't have Medicaid. Everything for them is pretty much going to be out of pocket. And they're going to experience probably the greatest access challenges of any population. And fortunately, though, we have seen that Moderna and Pfizer have announced that they will have patient assistance programs for their vaccines, which means that for people who are uninsured, they should be able to get the vaccine still at no cost to themselves, but they'll need to participate in that patient assistance program to get the benefit of that. So it's an extra hurdle that people aren't used to, but there should still be an access channel for that population if they are interested in getting vaccinated. There are still some supplies that are available from the Strategic National Stockpile for COVID's tests, treatments, and vaccines. And as long as those supplies last, people will still get access to them, hopefully at low or no cost. But those supplies will eventually run out, and we don't really have an easy way to know right now, like what remains in that stockpile. Congress can purchase additional things and to add to the stockpile, but that's not a guarantee. And so we're kind of preparing for this full transition to happen, and when those supplies run out, that everything moves to traditional coverage. And the last point on this slide is state programs. States can still have access programs to help people get tests and treatments. They can have their drive-through sites to ensure that people can get tested if they need to, but that's something that states have a more limited budget to support. So it's harder to rely on those things for long-term strategy. So reporting and surveillance is going to change a little bit too. So on the screen here, I have a map that shows what the levels of community transmission are. And there's a link to that map at the bottom of the screen. This is pulling from the CDC data that shows us really how is COVID spreading, what's the risk. And that's something that we might not have the same visibility of after the end of the public health emergency. So there's kind of two big types of reporting that happen here. One is the hospital reporting data, and the other is the laboratory reporting data. So hospitals is telling you, how many people are in the hospital sick with COVID. The laboratory data is telling you how many people are testing positive with COVID in the PCR tests. And so hospital data is going to continue through 2024, but the reporting will be less frequent. However, the laboratory data is going to change more significantly. HHS will no longer have the authority to require laboratories to send their test data to CDC. So that's going to make it harder for us to see what the test positivity rate is across the country. So a map like this, where we can see community transmission, it's not going to be as accurate. It's not going to be as up to date or timely. So I've got a second chart here from the same source that shows over time what the aggregate levels are. And this is up to date as of today. The real thing that I would, focus on here is that, we still have higher case counts than other times during the pandemic. There were other times where it was lower than this. And one thing we'll also lose visibility on is the vaccination data from the states. It'll be a little harder for us to see, what percent of the population in those areas is or has received their vaccine or booster. So coming up on my last 2 slides here, we got a lot of questions about patient safety, specifically in respect to healthcare facilities. And it's something that there's a lot of concern about because a lot of hospital systems have moved away from masking mandates for their staff, in the past couple of months. And that's happening because there was an OSHA rule that lapsed the emergency temporary standard. And the agency has started rulemaking for a final rule that would touch on topics like masking, vaccination requirements, ventilation, physical distancing in healthcare facilities. And as of January of this year, it's under final review by the Office of Information and Regulatory Affairs. Unfortunately, we don't really know what's in that final rule, but we're keeping an eye on it because if that gets passed and it has certain requirements, hospitals may find that they have to go back to masking for their staff. And that could be, viewed very well by vulnerable populations, but we're keeping an eye on that. I see a question in the chat about how can we impact OSHA's decision. Right now, things are kind of happening behind closed doors, and people haven't been able to talk about it publicly. So there's not a comment period yet, but when one does become available, make sure you stay in touch with us because we will be engaging with that to make sure it reflects the concerns of the community. So kind of to wrap this all up and to put it in a bow, when the public health emergency ends, access to vaccines, tests, and treatments, and access to telehealth services, this is a shifting landscape. For some people, depending on their source of coverage, the changes may be minor and really might feel like more of an inconvenience. But for others, they might have to choose how they're going to include COVID-19 tests or treatments in their limited household budget. And even worse, a person could get sick with COVID and get sticker shock at the pharmacy and choose not to treat the COVID with the tools that we have available. And that will lead to, of course, worse health outcomes. So we'll know less about how COVID is spreading around us, the tools that we need access to defend ourselves against COVID are going to be more limited. It's not guaranteed anymore. And we may face greater exposure risk to COVID in our communities. And the patients who do get sick may experience worse health outcomes due to financial access barriers. So we fear that being overly optimistic, I say we pandemic patients, being overly optimistic about the end of the pandemic will expose Americans to further illness, disability, and death. But there are some steps you can take right now to equip yourselves with the tools that you need to stay safe. You can stock up on home tests while they're covered by insurance or through the U.S. Postal Service. You can get 4 per person per month covered for free. So you should be able to get 2 more rounds of that before the public health emergency ends next month. Also, you can talk to your healthcare provider about getting your COVID vaccine or booster for free while it's still free, if that's a choice that you'd like to make. Also, make sure that you've established in-person care with any doctors that you're seeing, that you established care with during the pandemic to make sure you can continue to get prescriptions from them if they're controlled substances. Also, make sure you talk to your out-of-state healthcare providers to see if you'll be able to continue receiving care from them via telehealth after the public health emergency ends. And we recommend continuing to wear a well-fitted face mask when you are around other people indoors. And this is just a personal tip from me about mental health and wellness. I encourage you to start to explore new hobbies and activities you can do outside in the fresh air and sunshine to just make sure you're staying healthy and staying active and doing it while safe. So that concludes my presentation, and I'm going to turn it over now to Liza Fisher, who will explore the perspective of long COVID patients.
Thank you, Andrew. So as introduction said before, my name is Liza Fisher. I reside in Houston, Texas, and I'm a long COVID patient. A little bit about my background, my story. I got COVID in June of 2020. I struggled to find healthcare and testing initially. It ended up being severe, and I was in ICU and then hospitalized in a rehab hospital from July to October of 2020. Then following the gambit, like many others, symptoms arose, and I went down the pathway of getting diagnosed with all of the associated conditions like dysautonomia, POTS, MCAS, hypermobility, MECFS, etc. Along this pathway, my privilege has also declined. I went from being fully employed and having private health insurance to being terminated, entering disability, both private and public, and now doing the transition onto public assistance with Medicare and whatnot. And so a lot of these topics affect me personally and many in my community. We reached out to see what questions from the community specifically, and I'd like to go ahead and answer those first. The first question, let me switch to the next slide, is how do I contact my representatives and advocate for accessing care? Well, there's a link provided, and you can go to Pandemic Patients COVID-19 Advocacy Center, and you can subscribe to the mailing list, get notified for advocacy opportunities when they become available. There's an engagement tool there that has guidance on how to be persuasive advocate, how to build relationships with your elected officials, and how to share your personal story effectively. Also, you can reach out to your elected officials directly for further guidance using some of the links provided. And some of the current advocacy opportunities that are available are contacting your elected official about co-sponsoring the Stop the Wait Act. Stop the Wait is what I actually testified before Congress about. And when you go through this process, if you do get accepted on disability, there's an additional 24 months after your approval date, not when you were claimed medically disabled, but approval date before you can get the Medicare or healthcare coverage associated with your disability. So this is an act to terminate that 24-month wait. And then the next advocacy opportunity is to contact your elected officials to co-sponsor the Care for COVID Act. And that provides resources for education for healthcare providers, furthering research with private-public partnerships, and much more resources for the community. Next slide. Next question, if I'm required to get a vaccine for employment, but I'm uninsured, how is this going to affect me? Well, like Andrew said, Pfizer and Moderna are creating those patient assistance programs that will ensure that uninsured populations have access to their vaccines. Again, the details are still being worked out, but this is a short-term solution for people who are uninsured. Next slide. Does this mean that tests will stop coming in the mail? Can I still get tests from the government? Well, the USPS will continue to distribute the at-home test kits from the government stockpile while the supplies last. Again, as Andrew mentioned, Congress may provide more funding to increase the supply, but we don't know if that will happen. And health insurance plans may continue to cover at-home tests, but there may be a cost-sharing portion required. Next slide. My child needs testing and we're on Medicaid. How much is this going to cost our family? Well, Medicaid will continue to cover the at-home COVID-19 with no cost sharing through September 2024. Again, there's a link that you can access to provide more details on your healthcare coverage and access. Next slide. Where can I get the treatments and what are the costs? Well, you'll still be able to get Paxlovid from your doctor, and pharmacists will still be able to prescribe it directly. However, the cost may be too high for some, and insurance plans may be required a prior authorization. Prior authorization, like example, you may have to have a positive PCR test before insurance will cover your Paxlovid. It's also important to note that there is a certain window of opportunity to get that Paxlovid. And so if you are, there's a time determination and some pre-planning required now to think about that, having your testing accessible in order to be able to get the Paxlovid in a required time. The government supply of Paxlovid was purchased, again, looking at that cost of what they got it and what might happen with the increase in cost. It's another thing that we need to plan for. And the uninsured may be responsible for paying a copay when getting prescribed Paxlovid, or paying the entire amount, which could be hundreds of thousands of dollars. So essentially, it goes to show that the uninsured are going to be affected the most. Next slide. Are there any impacts to my ability to access off-label treatments and associated conditions or emerging treatments? So products authorized by an emergency use authorization will remain available because the National Emergency Authority allows for EUA products to be marketed in a separate than public health emergency. The FDA has the authority to issue new EUAs and amend existing EUAs during the first period. In general, off-label treatment should not be affected, and there is a link to explain more of that. Additionally, I had a private conversation with somebody just yesterday who is having trouble and is in the VA system. And I'd like to note that there is a link. The VA does go through a different formulary and has their own formulary for what drugs you can access or not. And there is a link to see what is available to you so you can plan ahead and if any other options are available to you as well. And I believe that's it. Thank you.
Thank you, Lisa, and thank you, Andrew. This has been super insightful. Like they mentioned earlier, my name is Alba Zola, and I have been co-directing the post-COVID clinic at Hopkins. And I was a physiatrist prior to the pandemic, treating spinal cord injury patients, traumatic brain injury patients, stroke patients, etc. People that had big impairments and helping them get back their function. So when the pandemic hit, we were approached by the pulmonary team because we knew that there was going to be a need for patients to get care. And we also had a sense of during MERS and during SARS-CoV-1, how there were patients that had not such a debilitating acute illness, but had prolonged symptoms that were quite impairing. So we joined forces and created an outpatient service for this group of patients. And that happened throughout the nation in smaller or in academic centers throughout. And I did not know anything about chronic illnesses. And I mean, other than the ones that I was treating, but the MECFS group, the dysautonomia, and how limited the access to care was to them. So I started first, sending them to a dysautonomia specialist. But when the waits were 2-3 years, we decided to start working together and creating pathways to address some of these medical issues. So I worked together with the Academy of Physical Medicine and Rehabilitation, creating manuscripts to teach physicians, primary cares, mostly, but other physiatrists as well, how to evaluate these patients and how to approach with treatments that are effective, at least in making their symptoms better. And as the pandemic evolved, the emphasis on COVID dwindled. The number of people that were having extra time to work for the clinics started to go away. So a lot of people were doing outpatient programs that were closed or research that had to be placed on hold because of the pandemic. So it initiated with a lot of volunteerism of people that were just unable to do their work when there was a lockdown. As that lifted, the resources started to get smaller and smaller for us, and many larger universities, like the one I'm part of, were able to get economic support from their medical systems to keep providing the services for this patient population. They were very limited, and definitely the millions and millions of patients that are suffering from long COVID don't have the adequate care available. There's certainly a gap in education to the physicians on how to approach this patient population and how to best serve them. So the problem comes, and I just wanted to highlight just this logistical issue. When you're having a long COVID clinic, you have patients that are impaired cognitively and physically. So we initially relied a lot on our telehealth services, and being in the state that I'm in, which is Maryland, geographically, there are many people over state lines in Virginia and Pennsylvania and West Virginia, where we are one of the main centers closest to them that have this type of treatment. And we were able to service those patients, and slowly, as there's waivers that were put in place by states, started to lift one by one. We started to have difficulty treating these patients. They had to travel in person, which would cost them a big flare of symptoms. And sometimes some of them don't have the financial means to be able to do that, to access service. So it became more and more increasingly obvious that we were not generating profits in terms of paying for the staff that's necessary to run this type of clinic. And it's a challenge. And we're really grateful about all the advocacy that has been put in place to support clinics, and they're starting to roll out announcement for fundings for support of these clinics. But I think that that's an area where we could certainly put more pressure so that we are able to fund the services, just like the patients with cancer have, just like the patients with heart failure or diabetes. There are certain programs that are federally funded that can help expand those patients receive services. So I think that given the timeline of the lift of the pandemic emergency, we are kind of in a gap time where we're not ready to service that population once they are uninsured, once they are unable to have access to medications and care. I also wanted to highlight my experience with equity issues. And this is, I think I probably sing into the choir here, but there's definitely the gap or the inequities that we had in healthcare in America have now widened and even broadened more after the pandemic, for multiple reasons, right? But it's becoming clearly evident in our patient populations that are able to access the level of care that can be provided by a long COVID center. And this is this is where we also need federal funding to be able to provide access to those people so that we can be serving equally patients of all that are coming from all places, because we know that long COVID and COVID affects more lower socioeconomic status patients, racially, people that are marginalized. All those patients have employment that make them more exposed to the virus. So we know that by numbers, people in this inequitable position are being more affected. but all clinics that are serving long COVID patients have a preponderance of Caucasian populations. And we are actively trying to make changes so that we're able to service them. Now, the other highlight that I wanted to say was that we want to, as a collective, there's a multidisciplinary PASS collaborative. We're trying to create standards of care, implementing the needed supports that the patients will need, whether that is social services, community health care, therapists, to really be able to optimize and standardize the care that's delivered to the patients that are affected by long COVID. And that leads to my last point, and that is that the care that we can provide right now is minimal. It's just temporizing some of the symptoms, trying to improve quality of care, trying to compensate to improve function, support the patients through that. But we don't have a curative treatment at this time, even though we may soon, in a few months, hopefully. There's still a bridge between the basic science and the clinical science, and how to match that, and the understanding of the pathobiology of the virus itself and how it produces this long COVID symptoms. So one thing that we feel very strongly about is education of patients, because these patients, you all are a very vulnerable population. You're suffering greatly. Your life has been turned upside down. It's just like having a traumatic brain injury, a stroke, spinal cord injury. It'll change your life just as much as those type of events. And we don't have proper treatment. We don't have standards of care. And it makes it very easy for these patients to become vulnerable to predatory companies that are trying to be for profit. So I think that's another area where the federal government could also have a role in order to prevent abuse of this vulnerable population at this time. And lastly, I wanted to mention that I think, what has been mentioned about the decreased access to Paxlovid, to vaccines, we have hard data. It's not just we think that Paxlovid, there's, very well created studies that have demonstrated that there's a decrease in long COVID risk with use of Paxlovid in the acute illness period. We know that. And we know that vaccines reduce the risk of long COVID. They don't make it completely go away, but they certainly reduce significantly the risk of developing long COVID. And we know that social distancing, masking, common sense things to prevent the spread of the infection matter. And having the public knowledge of the level of infection in the certain community that they live is going to be very important for patients to be able to choose to implement those measures when there are higher levels of spreads within the community. So all of this, kind of health, community health impacting access to knowledge, to levels of the virus in their community, it impacts greatly in a negative way. And there's not enough public understanding of what long COVID is in order for people to understand the risk that they take when they are not implementing those strategies. So another point is education to the public on exactly what long COVID can look like. And in order for them to really make an understanding and educated decision on whether they want to implement certain measures or not. So I just wanted to highlight those points, and I'm happy to discuss more and answer any questions from the panel or public.
We had one question in the chat that I think you touched on, but maybe you could ask or answer a little more specifically. The person asked, Are the long COVID clinics funded by NIH or the hospitals, and will they close due to lack of funding?
Currently, the post-COVID clinics are funded by hospitals system. There's no proper funding. There's an announcement for funding that opened on April 7th for proposals for funding of long COVID clinics that are already existing. This will, I think the deadline is June, the first week of June. So we're actively working on that. There's been $9 million allocated. My understanding is they're trying to fill in they're trying to sponsor 9 clinics throughout the nation. So that's just like a little scrape of the surface of what we really need, and definitely came pretty late, I would say, knowing the climate of our clinic status at this point throughout the nation.
Want to ask? We'll give you just a minute or so to type those in if you've got anything. And then we will close here in just a moment.
There was a question posted about why the CDC won't say that it's airborne. I don't know. That's the answer. I'm not sure why. I mean, there's a lot of pressures from different angles that may be influencing the decisions of their public statements and recommendations.
If any do come in right before we close, we got one here. Rebecca saying, thank you so much for your hard work. Sadly, this is not encouraging. Definitely empathize with you on that. Doing what we can to make the picture a little rosier, but yeah, things will be a little unsteady.
I just ordered my family's free COVID test, thanks to you, and I will make sure that all my patients do that this next few weeks.
Great. I was just caught coming out of Walmart with my arms full of them, so I'm trying to get mine too. Okay, we have one more slide to get to as we close. Rebecca mentioned that she wasn't eligible for Paxlovid. That might have been because there are a lot of medication contraindications with Paxlovid, where it might be unsafe to have it if you have certain medications you're taking. So there are certainly some access restrictions on Paxlovid that are not financial, but more practical.
The medical restrictions are very loose, the way that it's worded. So in terms of medical qualifications to receive Paxlovid, it's very much at the discretion of the provider. I mean, other than you're positive for COVID and you've had symptoms for less than 5 days. So if you're within that group, if you have long COVID, I consider you at high risk. And I think most of the medical community does too. So, but yeah, if that's the issue, that shouldn't be the issue.
And Rebecca asked if it's common to receive molnupiravir. It's not as common because the emergency use authorization on that medication only allows people to get it when they can't access Paxlovid as a first line option. So that may have been why you received that. So to close here, because we're about at the top of the hour, today's webinar was facilitated and presented by pandemic patients and COVID survivors for change, along with Dr. Azola from Johns Hopkins. I want to thank everyone for their presentations today. If any of our guests would like some more information on our organizations, our links are here on this page to our website. And we have one final slide where we'd like to announce that we will be going to Washington, D.C. Next month on May 15th to host a congressional briefing about long COVID so we can educate members of Congress and their staff about this extremely important issue. There is a QR code up in the top right corner that you can use. We are having a fundraising campaign through the end of this month to raise the money that we need to host that briefing. So if you're able, we encourage you to support our efforts so we can have a great event and get some policy changes implemented in Congress that will help patients with long COVID. So that is all for our presentation today. There will be a recording available afterwards if you are interested in rewatching this or if you missed out on the original broadcast. But thank you again for everyone for your participation, your questions, your presentations, and we'll see you all soon.
Bye, everyone. Thanks.